of your subtypes, the inflammatory type, certainly I think our audience really appreciates the impact of gut health on inflammation. Mm-hmm. And we've also talked about how we can consider the oral cavity as the first section of the gut. And so this is where periodontal health can be very important. And also how in some cases there can be dysbiosis in some instances that are a byproduct of mold exposure, but where someone can have dysbiosis in the sinuses. Yeah. So kind of this main mucosal tract as being a huge source of inflammation, certainly agree with that. And I'm wondering, are you finding that is the most common? Is that why it's considered type 1?
So, yeah, insulin resistance is probably the most common contributor to Alzheimer's disease. And as Professor Ed Getzel from UCSF showed by looking at neural exosomes, and there are about 1.2 billion of these little 100 nanometer vesicles floating around in every cc of your blood, they reflect what is going on in the brain. They derive from neurons and other cells in the brain. And as he showed, there is the signature of insulin resistance in virtually everybody with Alzheimer's disease. However, inflammation, as you indicated, which what we call type 1, is also a very common contributor, and one that's absolutely critical because the various cytokines that are produced during neuroinflammation are damaging to the brain. They are a part of Alzheimer's. And in fact, the amyloid beta itself is part of the innate immune system. So just as we've heard from COVID-19 that cytokine storm is such an issue, and that COVID-19 has essentially compressed all the risk factors of Alzheimer's down into 2 weeks. So with people who have inflammatory Alzheimer's, these cytokines do damage, and in fact, the amyloid beta is one of these. It's although not a cytokine itself, it is part of the innate immune system's response, and it does produce a downsizing response in the brain, which is what Alzheimer's actually is, a downsizing response in response to specific insults, such as you indicated, chronic sinusitis, changes in oral microbiome, changes in gut microbiome, leaky gut. These are all critical. And by the way, when the pathologists look in the brains of patients with Alzheimer's disease, what they find is they find various organisms, including P. gingivalis from periodontitis, T. denticola, F. nucleatum, all from oral microbiome. They find candida, for example. They find various mold species from the sinus. So absolutely, there is much more communication, not only between gut and brain, but between the rhinosinal microbiome and brain and oral microbiome than we ever thought before. And this is absolutely critical to address.
Sure. And I think they're obviously fantastic points. Just as one reminder for our audience, there was, I believe, a meta-analysis published that found that oral probiotic administration can lead to a clinically meaningful improvement in periodontal disease or periodontitis. So not to say it's all about probiotics or the gut, but certainly whenever we can find a simple measure or therapeutic like probiotics that may also help with oral dysbiosis, that can be helpful. I offer that because it's sometimes not the most straightforward getting opinion from a dentist. Some dentists are more forward thinking than others. And so some feel in any given individual, if they get 3 different dental opinions, one person may say everything's fine. The other person may want them to do a 12-month mercury detox protocol for the one filling they had 18 years ago. And, you kind of have these extremes. And so wherever we can help you have a intervention that could help with your oral cavity health that doesn't require a lot of testing and specific treatment, that's a win. Of course, take this case by case. And if there is some kind of festering infection, make sure you see that through. But just a bit there that may be salient to those wondering if their oral health is where it should be.
Absolutely. This is a really important point. And as you know, there's a whole group now of oral systemic specialists. So these are people who are dentists by training, but are now looking at the relationship between the oral microbiome and systemic illness. And as you know, it's found to play a role in atherosclerotic plaque, in colorectal cancer, in cognitive decline. They're finding these same organisms in the brain. So I think this is a really important and emerging field.
Yeah, fully agreed. And one thing to also point our audience to, Mark Brehenna wrote an excellent book called The 8-Hour Sleep Paradox. And he's made some very interesting connections that dysbiosis in the mouth and other similar findings in the mouth, dry mouth, burning tongue, receding gums, some of those may be due to nocturnal or nighttime mouth breathing that may be an indicator of underlying sleep disordered breathing. So just keep your eyes and ears open to the fact that if there is a chronic issue or issues in the mouth, part of that may be due to mouth breathing, especially at night, which is kind of a double negative because not only does it throw off your oral health, but obviously it impedes your sleep quality. And if you haven't read Mark's book, it's 120 pages, very simple read, but really loaded with action items. So that's something else for people to kind of keep in mind. Because you're making a great point, Dale, that the mouth has kind of not been given its just attention, and I think it's finally starting to get the recognition that it deserves.
Absolutely.
Hey everyone, let's talk about one of my favorite tests for digestive health, the GI map from Diagnostic Solutions, who has helped to make this podcast possible. Now, if you've been reading any of the case studies that I've published in the Future of Functional Medicine Review clinical newsletter, you've likely seen that this test, the GI map, is a test I frequently use in my practice. Why? Well, one of my favorite things about this test is it has excellent insurance coverage. So this is a few $100s I save patients. This lab is also CLIA certified, which is essentially the Quality Assurance Bureau for labs. So it's important that these labs are being monitored, not cutting any corners. That's where you get your CLIA certification. Now, this test uses quantitative PCR technology, so it's a DNA test, and you'll get a good read on dysbiosis with this test because they will assess and report out various types of bacteria, yeast, and parasites, including protozoa, worms, and amoebas. They also have some valuable and helpful clinical markers like calprotectin, which can help rule in or out inflammatory bowel disease, and zonulin, a marker of leaky gut. So head over to diagnosticsolutionsLab.com, diagnosticsolutionsLab.com to learn more and to order your test.
So, question regarding insulin resistance. Well, first a comment then a question. So my thinking is depending on the patient population you work with, that will be more or less of an issue. For me, in my clinic, we have many forward-thinking patients who are very well educated and they're paying attention to sleep, to exercise, to diet, all these kind of diet and lifestyle fundamentals. So it's much less common that we'll see insulin resistance in our population. Now, that's more the exception than it is the rule in the United States, but just something for clinicians to be aware of, because my fear is in some clinicians hearing that they're going to force an insulin resistance solution to someone who may not be insulin resistant, and they may overlook their gut health. So just something to be aware of, because it's most common. We have to offset that with the population that you're working with, and the more progressive and invested in their health someone is, ostensibly the less insulin resistance or insulin resistant they may be. But I did want to ask you how you're defining that. One of the things obviously can be used is a fasting blood glucose. Are you looking at that just being within range? Is there a nuance in terms of how you're looking at that? Are you juxtaposing that with hemoglobin A1C, even though that can be confounded by other variables like inflammation? So how would a clinician say, yes or no, generally speaking, I should be considering insulin resistance with this individual in front of me?
Absolutely. So typically we are using HOMA-IR. So, you want to have your fasting blood sugar times your fasting insulin divided by 405.45, and that'll give you an idea. We'd like to see it around 1. As it starts to drift up above 1.3, 1.4, get up to 2 and 3, that is very significant insulin resistance. So that's what we're using. But, you bring up a good point. For all of us, increasing data set size, being able to look more and more carefully at what's actually going on. If there's a real suspicion, of course, an oral glucose tolerance test with insulin is the most sensitive. But for most people, you don't need that. Just looking at the HOMA-IR, very helpful. And having computer-based algorithms that work with us as physicians to allow us to get these much larger data sets. We now have an app that we've developed with a software company so that you can actually look at all these different things. That is the future for all of us, to be able to look at larger data sets, to get better looks at people, better insights into the critical factors that are driving, in this case, the cognitive decline, but of course for others in other areas. And you're absolutely right that the that the gut health has been, again, one of the most common things. And getting gut healing. So many of these people have leaky gut. Getting appropriate probiotics and prebiotics, all of these absolutely critical. And of course, optimizing microbiome. This has become such a huge field, the relationship between the gut microbiome and the brain, and Parkinson's, in Alzheimer's. This is a huge issue. Of course, in ALS as well. These published papers on all of these areas.
And regarding the HOMA IR, I'm just looking up a few things because I've actually been a bit critical of this measure in the past, but I'm certainly open-minded to that. I wasn't clear on how well it translated clinically, and it seemed like there may have been less data. Well, obviously there's less data than using a fasting blood glucose. Doesn't mean that fasting blood glucose is better, but that was part of my rationale. Was it seemed like some of the nuances in how to look at HOMA IR were still being worked out. That being said, I haven't done a very deep dive on this. So that, if I'm correct here, is fasting insulin times fasting glucose, which is, I believe, what you said a moment ago?
Yes, divided by 405.45. So the idea here is, we do see a lot of people, we'd like to see their fasting glucose in the 70 to 90 range. And they, you may have someone who's got a fasting glucose of 85, but now their fasting insulin is 30. Okay, they're working very, very hard to keep their fasting glucose where it is. So they actually have a very high HOMA IR, and they do have insulin resistance. Alternatively, as their insulin starts to fail, their fasting insulin may be down at 1 or 2, but now their fasting glucose may be up at 120, that sort of thing. So that's why I think it's helpful to take both of those. And as you said, also hemoglobin A1C, to take that into account. So they all give you very much, complementary information. The other thing that we've seen a lot of, by the way, is with using continuous glucose monitoring, been such a helpful thing. We see not only people who are spiking, often from foods that they consider to be very, quote, healthy foods, but also what happens, they go to bed and they're dropping down into the 40s and 50s, and they didn't understand why they were waking up in the middle of the night. And it's not always obvious. It's not always that they're, drenched in sweat or things like that. They're waking up not realizing they're having hypoglycemic episodes. Very bad for your brain, as you know. And now with CGM, they're able to say, aha, I need to smooth out my glucose curve. I need to lower the carbs in my diet. I need to increase the good fats in my diet, make sure my protein is, mid-range, maybe 1 gram per kilogram, that sort of thing. And if I can smooth out the curve, I won't have those damaging hypoglycemic events in the middle of the night.
Right. Yep. And that's certainly something that we've talked about in the podcast before. One of the things that can be helpful for that, outside of just getting their diet more dialed in and finding the best macronutrient balance for them, at least what I found is having some people have a snack when they wake up to help prevent or bring them out of that hypoglycemic event. That's, I think, more of a sub-population recommendation, because as people become healthier and healthier, they should be able to maintain that fasting status throughout the night. So I want to be careful to say that's more of a while we're working on your metabolic health recommendation, not necessarily something that should be done in perpetuity. But would you have any concerns with employing that method in more of the acute phase application?
Yeah, no problem. No, I think that's fine. I think the main thing is that we want to do everything to change the ratio. People have when you have cognitive decline or risk for cognitive decline, you have a lot of synaptoclastic signaling, things pulling back on your synapses, and that includes all the things we've talked about, and a much less synaptoblastic signaling, making and keeping synapses. So we want to do everything to optimize your chemistry, and it includes your gut health, of course, and your sinuses and your gut and your microbiome, your oral microbiome, and all the things that we've been talking about. We want to change that ratio. And so, yes, we'd like to avoid these periods of hypoglycemia as well as of hyperglycemia.
Related question for clinicians who are trying to incorporate more of this into their blood workup assessment. Do LabCorp or Quest have a blood glucose with insulin that also gives you a pre-calculated HOMA IR score, or do you have to just do the math out? I mean, not that it's hard math, but the easier we can make it on a clinician where they have it in the report, the better.
Absolutely. And actually you can get the entire panel that we use. So if you look, for example, just at drbredesen.com, you can actually get a cognoscopy, or just look at mycognoscopy.com. So we recommend, just like we all